Good afternoon, everybody. I'm Marty Goldman. I just wanted to welcome you to our April Controversies in Cardiology. And I want to welcome for the first time our colleagues in Jupiter, Florida. Dr. Gonzalez-Loveday set up this broadcast live to them, and I hope they appreciate the time and effort he put in to make this happen. And hopefully this is the first of many educational forums that you join us in. Today's Controversies is really a wonderful opportunity to sort of look at the nexus that's occurring between subspecialties in cardiology. And this is one that Dr. Fuster actually predicted many years ago was going to emerge as a common problem facing both, and that only by working together will electrophysiology and heart failure people be able to really solve this issue of rate, rhythm, and heart failure. An important problem that we have actually a wonderful panel. The moderator for today's program, Dr. Fuster, has yielded the floor to Dr. Tony Gomes, Professor of Medicine and Director of Consultative Services, CVI, and the Senior Consultant of Cardiac Electrophysiology. For those people at Jupiter who may not have seen this before, this is a very interactive panel discussion. Our fellow will give a few-minute preamble about the subject, and then our moderator peppers questions across the panel of diverse individuals who will include this evening Valentin Fuster, Physician-in-Chief, Director of Mount Sinai Heart, Director of the Zena Michael Wiener Cardiovascular Institute, and Marie and Jose and Henry Kravis Center of Cardiovascular Health, the Richard Gorlin Research Foundation Professor of Cardiology, and Editor-in-Chief of JACC, Journal of American College of Cardiology. We also have the privilege of having Srini Dukkapati, Director of Electrophysiology Fellowship Program, and Assistant Professor of Medicine, Donna Mancini, who was a fantastic new recruit to Mount Sinai, Professor of Medicine here, and Sean Pinney, Director of Heart Failure and Transplantation for the Mount Sinai Health System, Director of Advanced Heart Failure and Cardiac Transplant Program. And as I mentioned, Sunil Agarwal will give us a few-minute preamble about this subject, and he's really put together an excellent monograph. Sunil?
Thank you, Dr. Goldman. More than 1 in 100 individuals living in the United States have heart failure. Results from few epidemiological studies recently have shown that while the incidence of heart failure with reduced ejection fraction may be on slow decline over the last decade, the incidence of heart failure with preserved ejection fraction is on the rise. The number of heart failure patients is projected to increase from 5.7 million currently to 8 million by the year 2030. The goal for the discussion tonight is to understand and explore the intricate relationship between heart rate, heart rhythm, and the pump function. Few months back, we had a controversy on heart failure with preserved ejection fraction, and we learned the complexity of the disease and the dearth of life-prolonging therapies available for that. The other side of the coin is heart failure with preserved ejection fraction, which comprise about half of patients hospitalized with heart failure. Most of the discussion today is relevant for heart failure with reduced ejection fraction patient or HFrEF patient, unless otherwise qualified. We are lucky to have the world experts in both the areas of heart failure and arrhythmia present in this panel and to share their wisdom. With my public health background and 2 kids at home, prevention always excites me. So let me start with the Metrocard Cynic study, in which patients with anterior ST elevation MI were randomized to either IV metoprolol or placebo. Cynic Center is led by Dr. Fuster, thus I will skip the details and wait for his comments and merely mention that these early results are promising and show that a simple, low-cost, and timely intervention can reduce myocardial damage and the ensuing cardiomyopathy, as evidenced by 5% higher EF in the intervention group than the placebo. A higher heart rate has been associated with higher incidence of heart failure. Once a patient has heart failure, a higher sinus rate is associated with higher rate of adverse events and mortality. In a recent exploratory analysis of recent trials, where most patients were on beta blockers, every 5 beats higher heart rate was associated with 16% relatively higher risk of poor outcomes. Based on the high-quality, multiple randomized controlled trials using metoprolol XL, carvedilol, and bisoprolol, beta blockers have a Class 1A recommendation for use in patients with HFrEF. It is important to note that they prolong longevity, but they may not improve the symptoms. Thus, it is incumbent upon us to provide better patient education to improve the compliance. As Dr. Fonero pointed out today, underdosing of beta blockers may be another important public health problem. Another rate-controlled medication, ivabradine, was approved by FDA in 2014. Ivabradine primarily acts on the hyperpolarization-activated cyclic nucleotide-gated channels, reducing funny current, and thus lowering the sinus rate without affecting myocardial inotropic or lusotropic state at low doses. It was approved primarily based on the results of SHIFT study, which was done outside of the US, which evaluated ivabradine versus placebo randomly assigned to HFrEF patient with EF less than 35% and a sinus rate less than 70 beats per minute, while either on maximally tolerated beta blocker therapy or amongst those with a contraindication for beta blockers. There was a reduction in heart rate by 15 beats per minute in the drug arm as compared to their baseline. There was a statistically significant reduction in primary composite endpoints of heart failure hospitalization or cardiovascular death. The endpoint was primarily driven by a relative reduction in heart failure hospitalization by 26%. Beyond heart rate, which is a reflection of autonomic tone, heart rate variability reflects the beat-to-beat variability in the heart rate. While heart failure patients often have low heart rate variability and several medications such as beta blockers, ACE inhibitors, digoxin, and also lifestyle changes like meditation and exercise have been shown to improve heart rate variability, our understanding on how to modulate heart rate variability to improve outcomes in heart failure patients is preliminary. An earlier trial, NECTAR-HF, randomized HFpEF patients to either vagal stimulation versus sham, and a recent trial, INNOVATE-HF, randomized HFrEF patients to vagal stimulation versus placebo without a sham. Neither of them showed any survival benefit, but they pave a way for similar trials which are more thoughtful. Moving on to the rhythm, there has been an improvement in our understanding of the pathophysiological relationship between premature ventricular complexes, a pretty common subclinical arrhythmias and cardiomyopathy. Following the counterintuitive results of the CAST trial, we have treaded the issue of suppressing Pvcs with great caution. Recently, multiple case reports, few case series, and large epidemiological studies have suggested that frequent Pvcs may lead to cardiomyopathy, including the reversal of cardiomyopathy with abolishment of Pvcs. The mechanism may not be similar to tachycardia-induced cardiomyopathy, but similar to AV and VV dyssynchrony as seen with RV pacing. And a high burden may be present for years before a patient may develop cardiomyopathy. Studies have suggested various burden threshold of Pvcs as causative of cardiomyopathy ranging from 16 to 26% with increasing specificity. It is also important to note that only 5 to 10% of patients with a Pvc burden greater than 10% may develop cardiomyopathy in a short-term follow-up. While few case series have suggested that Pvcs originating from the right ventricular outflow tract and those which are monomorphic and high-frequency burden may be pathogenic, a recently well-done study suggests that higher burden of Pvc arising from the coronary sinus may be more pathogenic as compared to other origins. Though ablation is highly successful in suppressing Pvcs in selected patients and has been associated with improvement in EF, studies looking at alternative therapies and outcomes are needed. Also, patients with HFrEF are at high risk of sudden arrhythmic death, and high arrhythmic death and implantable cardioverter defibrillator for primary preventions provide significant survival benefit. Despite ICD therapy, the arrhythmic death rate remains pretty high, and the quality of life may suffer because of appropriate and inappropriate shock. SMAS VT and VTEC studies which examined the role of catheter ablation of SCAR VT, did show a reduction in shocks significantly, but were underpowered to test for any survival benefits. Also, the timing of ICD implantation is controversial in the setting of an extensive MI or a non-ischemic cardiomyopathy when a patient who is young and has very little comorbidity may benefit from it, but current guidelines, because of the high non-arrhythmic death associated in the very short duration after MI, have associated reimbursement with delaying it beyond 40 days or 3 months for such patients. The other aspect of this is CRT, cardiac resynchronization therapy, which has shown to be of benefit in patients with wide QRS complex and left bundle branch block. There has been an improvement in our understanding of selection of patients for CRT recently, since the publication of appropriate use guideline in 2013. CRT is beneficial in HFrEF patients with a QRS greater than 120 millisecond and a left bundle branch block. They may be less useful or even harmful in the setting of non-left bundle branch block and may be useful only when the PR is prolonged beyond 230 milliseconds. 2 studies which have tested CRT in the setting of narrow complex and echocardiographic defined dyssynchrony were negative. Lastly, atrial fibrillation is the most common clinical arrhythmia. It often coexists with heart failure. AF may less often cause heart failure, but more commonly influence its severity and management. Rhythm control is advisable when AF is thought to be causative in cardiomyopathy in a patient without prior history of either. Whereas in other settings, initially a rate control approach may be worth trying while making the patient euvolemic and removing any inciting factor. In a rare circumstance when rate control is not possible, AV nodal ablation with biventricular pacing has been used. I will conclude by mentioning the results of 2 studies attempting to see if rhythm control is superior in patients with HFrEF and atrial fibrillation as compared to rate control. The first study, HFAF study, which tried to cardiovert patient using electrical cardioversion and antiarrhythmic drug, didn't show any superiority of rhythm control over rate control. The second recently published trial, ATEC study, showed that AF ablation was more successful in suppressing AF in HFrEF patient, as well as it was associated with a lower 2-year mortality of 8% as compared to 18% with amiodarone. The interaction between heart rate, heart rhythm, and pump function is pretty complex, and it requires bedside thoughtfulness and team-based discussion, as Dr. Fuster and Dr. Pinney has taught us. Also, rigorous science, including implementation science, is needed to improve outcomes in HFrEF patients who have mortality worse than most cancers. Thank you.
Thank you, Sunil. Very complex subject, but these are the patients we deal with, when both rhythm disturbance and systolic dysfunction are present in the same patient. So I agree that we have the world expert on this complexity, Dr. Greg Fonarow. I will say a few words about him. He obtained his MD degree at the University of California in Los Angeles. He had his internship, residency, fellowship in cardiology, and then a fellow in cardiomyopathy at UCLA. And then he continued to be in the same institution where, from the professional point of view, in 1993, he got a staff position as an assistant professor, and eventually he became professor of clinical medicine and the Elliott Corday Chair in the cardiovascular medicine and science at UCLA. Now, in terms of professional activities, he has been so involved not only with his mother institution, but with the American Heart Association, American College of Cardiology, in terms of guidelines and being part of multiple committees, executive committees. I prefer not to really, there's no need to go into the details. He has a number of honors and awards. First of all, locally, even before he finished medical school, the outstanding medical student. at UCLA, then the Fellowship Teaching Award at UCLA, the Faculty Teaching Award twice, and then also he has the American College of Cardiology Bristol-Myers Travel Award, and then the Proctor Harvey Young Teachers Award from the American College, and from the American Heart, the Laverna Titus Young Investigator Award, and then the American Heart Association Award for Meritorious Achievement. Now, he has multiple grants and has participated in a large number of studies. Actually, he has been the recipient in one way or another as a principal investigator, co-investigator with 10 NIH grants, 5 AHA grants, and then he has been very decisive participant in actually 23 trials. I had to count them. So we have an outstanding individual here. Certainly he's in the editorial board of Circulation Heart Failure, Circulation Cardiovascular Quality, Journal of Cardiovascular Pharmacology and Therapeutics, and of course in all the journals of the Journal of the American College of Cardiology. Now, his contributions are numerous, actually. He has, I think, near 800 papers, and he has actually been, he has contributed in all the aspects of heart failure, structural, clinical, pharmacological, etiological, and then certainly in this frontier between heart failure and rhythm abnormalities. He has been a significant contributor on the field that we are going to be discussing today. So let me give you, Greg, this plaque just for you to remember today, and we give it to you in the name of Anandi Sharma, visiting professor, is the father of Dr. Sharma, and the Simon Dag Memorial Lecture. Thank you very much for being with us. And then let me give you this, and be sure we don't lose that. Thank you.
Oh, thank you.
Okay, you can sit here in the middle. And now we are going to call the experts. I pretend to be an expert, but we have here Srinivas Dukapati, Donna Mancini, Simpini, and then, of course, Sunil Agarwal. And Tony Gomes is going to drive the show today.
Good evening, and thank you, Sunil, for a very good summary on a very complex and diffuse subject. What I'm going to do is I'm going to start from the top of the heart and work my way down. Okay, so let's start with heart rate, and let me begin with you, Greg. Is the concept of resting heart rate as a prognostic factor and a potential therapeutic target generally accepted? In this regard, is there such a thing as heart rate related, mind you, not essentially tachycardia related, cardiomyopathy in CHF? I don't want you to deal with ibuprofen, which I will come to later on. So if you can just expound the concept.
So this has really been an exciting and evolving area. We have certainly known for decades that heart rate has been an independent risk factor for developing heart failure in the first place, and a risk factor for mortality and hospitalizations in patients with heart failure, but often was thought to be a marker and not necessarily a mediator. And early on, with the beta blockers demonstrating improvement in clinical outcome, it was somewhat dismissed that the heart rate lowering had much, if anything, to do with it. In part, other drugs like calcium channel blockers that could impact heart rate to some degree had not improved clinical outcomes. It was felt that patients with pacemakers in that received beta blockers still had improvement in outcome, and this was all neurohormonal inhibition, and just, sicker patients have higher heart rates, but the lowering heart rate would not be a mechanism of benefit. But on the other extreme, it was certainly known in patients with persistent resting tachycardia at very high rates could develop cardiomyopathy. And one of the earliest models for cardiomyopathy in animals was rapid ventricular pacing. And so this concept of that there could in the extremes be this contribution was well recognized. In analyses, though, of the clinical trials of beta blockers, much of the benefit did seem to associate with the heart rate lowering, but no way of really untangling it. And it wasn't until more recently where seen despite beta blocker therapy that heart rate continued to be an independent risk factor, and having drug that could modify that and more precisely test that there's been this increasing focus. So certainly long-standing recognition that it is a marker for worse outcome in heart failure in those at risk, but more recently recognized that it could actually be a mediator and target for therapy.
Thank you. Now, beta blockers undoubtedly have had a significant impact on heart failure survival. The effect in CHF and in myocardial infarction is multifactorial. Rush and co-workers have demonstrated a shift in mortality in the last decade from cardiovascular to non-cardiovascular death, mostly attributed to the use of beta blocker. Now, this question is for you, Valentin. You have been involved in the Metrocard Cynic study. However, the early BAMI trial did not show benefit from infarct size or ejection fraction following beta blocker pre-PCI. Do you want to elaborate and let us know when to start beta blockers in patients with MI? And is there a role for IV beta blockers in the ambulance or in the emergency room?
Yeah, first of all, there are 3 studies of beta blockers in acute myocardial infarction in the acute phase. First is the Chinese study with thousands of patients in which the average entry was 11 hours after myocardial infarction. The second study was ours, and the average entry into the infarction was actually 4 hours. And it worked in terms of ejection fraction by MRI at 6 months. And the third study, also ours, it didn't work. But what we found out is we entered patients who actually was not in Spain, actually was in Norway. The patients entered at an average of 7 hours. And then what we did is we tabulated recently all the studies done with beta blockers, and there is no question is aligned, and that is earlier you start a beta blocker in the phase in acute myocardial infarction, higher is the likelihood that you are going to preserve ejection fraction. So this in itself is leading us to now do a definitive study with 2,000 patients in which we are going to use beta blockers in the first 3 hours. And we will only confine this to acute myocardial infarction over the anterior wall, because we think that you cannot achieve a lot when you look at the inferior wall, which was the last trial that we made a mistake. 50% were patients with a very benign myocardial infarction. So this is the trial that we are going to undertake, and there is not going to be ventricular function. We are going to look at outcomes in a long term.
So you would use it in the ambulance as well as in the ER. Thank you. This is for Sean and Donna. Either one of you can start, and then the other can follow. What about immediately post-MI in the setting of LV dysfunction? ACE first, followed by beta blockers, or both together?
It depends on the severity of the heart failure. You know, generally my approach is ACE first, followed by beta blocker. But if the patient has only mild LV dysfunction and no overt heart failure, and just a drop in ejection fraction, then beta blocker first.
Sean?
Yeah, I agree. They're going to leave the hospital on both an ACE inhibitor and a beta blocker. So tailored to the individual patient.
Thank you. This question is for Greg. You are aware the main program director for the Optimized Heart Failure Program. So what about beta blockers in decompensated CHF? Do you start, stop, or cut down the dose on those already on beta blockers? Obviously, Dr. Fuster, Sean, and Donna can join in if they, if the opinion is contrary to yours.
So certainly the traditional teaching had been that patients, one with heart failure, shouldn't be treated with beta blockers, but even as the evidence came out from the randomized clinical trials, many felt that when patients were hospitalized with decompensated heart failure, that the beta blocker dose should be transiently held even in the absence of contraindications. But in looking at data where administering inotropes to patients with heart failure outside of cardiogenic shock was associated with worse outcomes, norepinephrine levels being associated with worse outcomes, elevated heart rate, worse outcomes. We were very interested in this, and in Optimize, so prospectively collected data, we're able to capture a number of patients and what was done with their beta blocker dose. In some patients, they were continued on beta blockers, others where it was transiently withheld, patients that were newly started during the hospital, and were able to report in JACC that the very best outcomes were those in newly initiated or continued on beta blockers, those that were eligible and never treated intermediate outcomes, and the absolute worst outcomes for those where in the absence of contraindications, beta blockers were withheld. Data from the ESCAPE trial showed similar findings, and so the guidelines did evolve to where the recommendation since 2009 is, in the absence of hypotension or cardiogenic shock, to continue beta blocker therapy in decompensated patients. Certainly data from Optimize It here show the vast majority of patients hospitalized with heart failure have relatively preserved blood pressure. It's really only about 5% of patients where systolic blood pressures are even below 90, much less below 80. So we can continue beta blockade. It's associated with better clinical outcomes, and really the rare case where you're developing cardiogenic shock where there may need to be adjustments in doses or withholding it or in the setting of needing inotropes. But that's a relatively small proportion of patients.
I disagree a little bit with Greg in terms of the usual approach to beta blocker use in decompensated heart failure and whether they should have been stopped. I think there was a lot of controversy for a long time, and people were very concerned that withdrawal of beta blockers would cause an exacerbation of heart failure from the Swedish experience. And I think that with time, clarity has been obtained because it's clear now that there are large data sets that support continuing the beta blocker and not discontinuing it.
Sean, anything?
No, I completely agree. I think just to reemphasize the point that Dr. Fonarow made, that 97% of patients who are admitted with decompensated heart failure are normotensive or hypertensive. And I think that that gives us an opportunity to reframe our thinking, which is that the default position is to continue neurohormonal antagonists, diurese patients through that, and even think about uptitrating medicines at the end of their hospitalization, because we know that the types of medicines and the doses of the medicines that patients leave the hospital are the ones that they're going to be taking 3 months down the road. So you can think of it from an outpatient perspective that if you receive a patient from a hospitalization, they're not receiving an ACE inhibitor, a beta blocker, or an MRA, and they say, well, when they're in the hospital, that was the perfect time to give the drug. If they didn't start it then I'm not going to start it now. And I think that partly explains the philosophy or the thinking behind why medicines don't get started as outpatients. So continue the beta blockers, increase the beta blockers before they leave the hospital if you can.
Thank you. This question is for Valentin. It is my feeling that cardiologists don't up-titrate and optimize the dose of a beta blocker, say Coreg or metoprolol. Actually, most of the patients I see in the clinic are on very small dosages of metoprolol, like 25, Coreg 3.25, at most 6.25. And these dosages are far below clinical, the ones recommended and the ones that showed benefit in clinical studies. Why do you think that is, and what is the solution?
Well, first of all, there is a concern about the heart rates. I think that's to start with. And the heart rate has served many of us as a parameter in terms of what dose you should use. I think there are experts here who will tell you that the number of patients that we are discussing today with low ejection fractions, they have a chronotropic problem. And they start, actually, it's not a small number, and they have started with a rather low heart rate. So I think this has made physicians very cautious, and you start giving the lowest you can. There is concern about dropping blood pressure, and there are a number of concerns. I have to tell you about the trials, if I may. You are the expert. There are a large number of patients who actually were removed from the trials because they didn't tolerate the low heart rate, they didn't tolerate the low blood pressure, and they had to get out from the trial. So whenever we talk about trials in beta blockers specifically, we are talking about people who tolerate the beta blockers well. And the dose being used is perfect, but this is not the patient we see every day. I don't know what comments you have to make, but I think it's very difficult to standardize or to give a high dose because of the trials. At least this is my view.
So it's certainly in the trials where some of them did have a run-in phase and did exclude patients initially that didn't tolerate certain doses. Others did not have the run-in. In general, the type of patients that get in trials have less comorbid conditions, tend to be a little younger. But the trials did show for those types that were enrolled, you can often get in about 75% of them up to that target dose and is well tolerated. And those short of that can't tolerate those full doses do seem to benefit at the highest tolerated dose. In older patients where by protocol there were attempts at uptitration, a trial called COHERE, and looking at real-world heart failure patients, all comers, did show the tolerability to get to target dose wasn't quite as high, but still 50–60% of patients were able to get there. I think the challenge as a clinician when the patient has a little bit of dizziness, are they over-diuresed or is it due to the beta blocker dose? If there's a little bit of fatigue, is that due to the beta blocker or is that their underlying heart failure state? So often we're left really with the matter of trying to personalize that dose, but recognizing when we can up-titrate, there's greater improvement in EF, there's greater improvement in clinical outcome, and it's worth that effort to really kind of prove this is a maximal tolerated dose, and if it is, great, but if we can go higher and it is well tolerated, it's certainly worthwhile.
Thank you.
If I could just follow up on that, you can't prove that you prevented a hospitalization, and you can't prove that you helped someone live longer by increasing neurohormonal antagonist. We don't have a feedback arm to tell us that we're doing the right thing. Now we're looking, maybe biomarkers might be some way to guide us and maybe give us some feedback that we're doing the right thing, but the reality is that you don't really know. So you have to put your faith in the clinical trials that demonstrated efficacy at the doses which were used in the clinical trials. Having said all that, side effects are real. So you can't see the benefit, but you do see all the side effects. And patients do feel poorly sometimes on these medications. Beta blockers certainly cause fatigue, they cause sleepiness, they cause depression. And as Dr. Fonero said, it's sometimes hard to tease that out whether or not that's a manifestation of their progression of their underlying heart failure or whether it's a side effect of the medication. And that then creates a ceiling where you say, well, maybe 6.25 of carvedilol twice a day is good enough. I think what's different from, let's say, a heart failure disease management program and general cardiology practice or a primary care practice is that we assimilate all that and then we keep going. And we keep increasing the doses of the medicines. And I think the only difference is that we have a higher tolerability of side effects. And because we've pushed through those early barriers and seen returns in that, gives us the confidence to do that again with the next patient. So the confidence to increase ACE inhibitors and beta blockers to higher doses.
Thank you. Now we go to the sinus node, which I have previously referred to as the maestro of the mammalian electrical system. And what a maestro it is. Metaphorically speaking, it can go from largissimo to adagio to prestissimo in an instant. So for the benefit of the audience, to talk about heart rate and its modulation, I think we need to understand sinus pacemaking. The sinus node has thousands of pacemaker cells. as shown in the 1970s by the Dutch Felix Bonke, and subsequently our own studies in the human demonstrated the same phenomenon. Recently, in a lecture, I was asked the question, what is so funny about the funny current? So, for the benefit of the audience, the funny current was discovered by Dr. Dario De Francesco, who was a Milanese physiologist working in England. And he worked on the rabbit sinus node in the 1970s, first in Cambridge and subsequently at Oxford. What he found is that the sinus pacemaker complex, or the sinus pacemaker cells, they are active when they hyperpolarize at about -40 to -50. And that hyperpolarization occurs when the funny current or the I current starts working. And it's a mixed current in the sense that it's a sodium-potassium current, and it's cyclic AMP dependent as well. It gets more stimulated with catecholamines, and the reverse is true with vagal stimulation. So the reason why it's known as funny current is that the other currents are activated during depolarization. This is the only current which actually is activated during hyperpolarization at -40 to -50. So the question to you is the following. Now we have this drug, ivermectin. Is there any role for it? In addition to beta blockade? And if so, what is the heart rate cutoff? And what dose do you start, and do you up-titrate the dose for maximum benefit? How long do you continue using the drug? Can you elaborate? Yes, Greg, it's for you.
So simple questions, right? So certainly we have a good clinical trial evidence base. There has been a little controversy that's been around the beta blocker dose. So the trial shift was patients in sinus rhythm, heart failure with reduced ejection fraction on background medical therapy on tolerated doses of beta blockers with a resting heart rate of 70 and above, and did show a reduction in the composite endpoint, mainly driven by a reduction in heart failure hospitalization. So I do think this has an important role on top of maximally tolerated beta blocker doses. The greatest benefit was seen in those with heart rates at rest of 77 and above. So the group between 70 and 76 had a more modest benefit. The hazard ratio was 0.93. The benefits tracked the heart rate lowering. Those who had very little change in heart rate had very little event reduction. Those with a heart rate reduction between 1 and 9 beats per minute had a modest reduction, and those with a greater than 10 beat per minute reduction in heart rate, and that seemed to track that benefit. I think there are certain patients that can't tolerate any dose of beta blockers or have an absolute contraindication. We have a drug that can provide benefit for those patients. That subgroup and shift, it was a very large benefit. For those, despite maximally tolerated beta blockers, where the heart rate is above 75, above 77, I think this is a very reasonable addition to the management of these patients in sinus rhythm, whether other medications have been optimized. And so I really think it has an important role, but it is critical to emphasize it's not in replacement of up-titrating that beta blocker to maximally tolerated, well-tolerated doses. The side effects are relatively minimal. You can start off at the recommended starting dose and up-titrate from 5 BID to 7.5 BID or down to 2.5 BID based on the response. The duration of therapy would really be long term unless there's recovery in ventricular function, in which case there could be some reassessment about its continued need. Is it as compelling as our drugs that reduce all-cause mortality? Certainly not. But preventing hospitalizations, and there was even a 5% reduced to 3% reduction in heart failure mortality, that I think this represents an important addition to our armamentarium. Where is the ideal heart rate in our heart failure patients? The nadir for mortality is somewhere between about 55 and 60. Below that, you do see a little uptick, so it's not a continuous linear line down. It doesn't apply to atrial fibrillation at all, but I think it is worthwhile to really look at that on-treatment heart rate despite maximally tolerated beta blockers and think about the addition of this drug.
Thank you.
You know,
Greg.
Yeah, well, I had a question about ivabradine. I'm sorry. Oh, I'm sorry. You can comment on it. Sure.
I was just going to say that I don't really think that ivabradine is an important addition to heart failure therapy. I think that there are very few patients that will benefit from this drug. I think that mostly you can up-titrate your beta blocker, and if you up-titrate your beta blocker appropriately, there's no need for the ivabradine. It did not decrease cardiac mortality. I think that the data from the SHIFT study was not all that robust, and I don't really see a big role for it at all.
Well, actually, I was going to make the same comment. What I was surprised about ivabradine, how the FDA approved the drug. That's unbelievable. First of all, there is a drop in ejection fraction of 2%, or increase ejection fraction of 2%. So from 30 were to 32%. And then the mortality, I thought was lower than 5%, the issue of mortality and hospitalization. But anyway, that's one of the greatest surprises with the FDA, that is so tough on drugs and how this drug was approved, just like...
I can't believe that it was approved because Signify and Beautiful were negative studies. There was only one SHIFT study, and I have tried to see if I could use the drug, and of the many patients that I follow, I've only identified one patient that I used it one time, and I can't be sure that it really helped him.
So I'm actually...
You know, we
pleasantly-
electrophysiologists have used it for inappropriate sinus tachycardia and also for POTS, but I guess the consensus over here is pretty much that it's not very effective. Sean, you have something to add?
I was pleasantly surprised that the FDA approved it. I was surprised, but pleasantly surprised. And first of all, you can say that it's safe, and the FDA is charged with making sure that drugs are safe and also efficacious. And there was data to show that it reduced hospitalizations, which is a good thing. Completely agree that it didn't improve survival. More importantly than that, if you look at neurohormonal antagonists, which have been shown to be life-saving in patients with heart failure, and if you look at other therapies like CRT, they have positive effects on ventricular remodeling, showing that reductions in left ventricular end-systolic or end-diastolic volumes. And we don't see that in the SHIFT population, which certainly would go hand in glove with its neutral effect on survival. Nonetheless, the thing that I like about ivabradine, I've only prescribed it 3 times. All 3 patients have tracked me down to say that it's the greatest drug that they've ever taken. One of them was an atrial fibrillation, so clearly this was a placebo effect in at least 33% of the patients who it's been prescribed to in my experience. But having said that, I think the interesting thing then is for us to dig just a little bit deeper and say, well, if there is a benefit, and you led off with this question, if there is a benefit to heart rate lowering, and if the heart rate lowering itself is the target, then why might it improve survival, or why might it improve outcomes in heart failure? And for that particular question, we don't have a good answer. We really don't know. I have some interesting hypotheses about why it might work, including the fact that if you look at across species, there are metabolic scaling laws that hold across all mammalian species, and even if you go outside mammals, it holds as well. And with those metabolic scaling laws, you also see that heart rate tracks with that. And the number of heartbeats that you have per life track with that. And so you have a fixed number of heartbeats. What happens in heart failure is that it's accelerated decrepitude. You just die more quickly. So at a very, very simple level, slowing down heart rate may actually just slow down metabolism, whether it's just slowing down cardiac metabolism and you preserve cardiac function, or whether it's slowing down cellular metabolism more broadly and you slow the aging process down, is one hypothesis. It's one that was promulgated a few years ago by Milton, and whether or not that was just Milton being Milton or whether or not there was really a grain of truth to that, I'm not sure. But I do think that there's something a little bit deeper there, and I think as clinical scientists, it's our duty to go and probe a little bit further.
Thank you.
I wanted to make a comment with respect to the EP when we use it for, there's some data about it for inappropriate sinus tachycardia and POTS that shows some positive effect. I don't think anyone uses it a lot, but in our collective group experience of 3 or 4 patients, we found 0% efficacy, and I'm not sure what all the excitement about the drug is.
That's in inappropriate sinus tachycardia.
Yeah. And one patient with POTS, which, I mean, amongst all of us.
Inappropriate sinus tachycardia is a very complex entity that we don't know anything about. Yeah. I mean, you know, the automaticity shifts from the sinus node to other areas, right to the junction. So to move on, this question is for Sunil. Now, you have reviewed the literature quite extensively on the subject. Are there any other methods to alter the sympathoadrenal system in CHF, like renal vein denervation or vagal stimulation, or are these just fads or gimmicks or tricks or whatever that we don't know anything about, or we are just doing it because we don't have anything else to do?
So I think from my review of literature, I found that this is an exciting area, but the trials I found slightly premature because I did not find much data in terms of animal studies trying to use some of these devices and look at what is happening. And I feel like these are some of these may be ahead of preclinical studies, which are much more needed before we go in terms of understanding how to program some of these devices, how much stimulation to give in order to accrue any benefit from them.
Thank you. Okay.
Sunil, I have to say that I thought you were missing one potential treatment for lowering heart rate in your review, which was an excellent review. But you didn't say anything about exercise and exercise training. And obviously that can significantly increase your heart rate, decrease your heart rate variability, and have multiple beneficial effects.
I mentioned it briefly without presenting much data for it, saying exercise and meditation and some of those things have been tried in heart failure patients. And again, similar to the studies with vagal stimulation, they have been shown to improve the quality of life. But I think the data on prolongation and survival is still not there.
Thank you.
And just to follow up on Donna's point, you know, it's very hard to stimulate parasympathetic tone. It's really easy to stimulate sympathetic tone, but it's not so easy to stimulate parasympathetic. And the ways that we do it are through exercise, and it's reflected in low resting heart rates. Again, that theme of low resting heart rate. And the second is through meditation, yoga, non-traditional ways of thinking about health. Some of the things that we want to incorporate in Mount Sinai Heart about focusing on wellness. But one of the more potent ways to lower your resting heart rate is through yoga and meditation. And you can really increase your parasympathetic tone, driving your resting heart rate down into the 20s and 30s. Again, I don't know if that's beneficial during that time period when you're down around 20 to 30, but overall, that is one way to stimulate the parasympathetic tone. The other theme in this is that it's really not easy to get there, right? I mean, who's going to go and run 4 to 6 miles every day? I think a lot of people in this room do, but outside this room in the clinics, not so much. Who's going to take the time to focus on yoga and meditation and things like that? But it clearly works.
Well, the recent trial, though, it was presented last week, in which you stimulate the vagal nerve through the mechanism of stimulating. People are shake up. In fact, what the patients say is they cannot even tolerate 1 hour of such a stimulation. And then the trial was completely negative over a few months of weekly stimulation of the vagal nerve. I don't know if you can comment about it.
So yeah, in Innovate HF, it was a completely negative trial. So it may not, it doesn't negate the fact that having parasympathetic stimulation is necessarily a bad thing. It may be how you get there is critical. So things like exercise and yoga definitely work, but stimulating the vagus nerve through an electrical stimulator may not be the physiologic way to do it. In Innovate HF, there are also high rates of atrial fibrillation. We know that vagal stimulation can lead to AF, so that might have offset some of the potential benefit that would have been realized by patients otherwise. So there's still a lot that we don't know. What we do know is that autonomic nervous systems are highly redundant, highly conserved throughout nature. There's a reason why they're there, and we're just beginning to learn how to perturb them, whether it's through renal denervation or through parasympathetic stimulation. There's a lot that we still don't understand.
One word about, you mentioned yoga. What class of CHF would you do that? I tried yoga. It's not, those positions are not easy. so I mean, I don't think you can do yoga if you have class 3 or. Anyway, so.
There are other
very brief,
lighter components. I will say there are other ways of modulating it. ACE inhibitors actually augment parasympathetic tone, restore heart rate variability. Bradykinin may have an interplay here. So there's a lot more that we need to focus in on, not just ramping down sympathetic tone, but augmenting parasympathetic tone. But how you do it may matter substantially.
Anyway, my wife did better, but I dropped out in about 20 minutes. Okay, I think I left out Srini for quite some time. Are you still awake? Yeah. Okay. So this is for you now. We have we are moving now to AFib. So we have a 55-year-old man who comes with rapid AFib in CHF, says he was fine until recently, progressively short of breath over a 2 to 3 week period. He drinks a glass or 2 of wine, denies any other history. Echo shows an enlarged heart, mild to moderate LA enlargement, and an EF of 25%. You're called for a consult, obviously. How would you proceed?
Yeah, you're talking about treatment of atrial fibrillation and tachy-induced cardiomyopathy. So new onset AFib, probably not. He's probably had it for some time. The treatment choices at this point are basically you have to restore sinus rhythm to reverse cardiomyopathy, and the treatment choices are either an antiarrhythmic drug or an ablation procedure. And it really depends on how I treat the patients, basically comorbidities. If they have a lot of other comorbidities, I think trying a medical approach as a first line is appropriate. Amiodarone, loading, and cardioversion would be my first choice in that group of patients. Certainly younger patients with less comorbidities, I'm more inclined to offer an ablation procedure. Now, at least with the new updated guidelines, they're no longer new as of 2014. I think in selected programs, you can offer that as a first-line therapy for patients who you want to restore sinus rhythm for.
Thank you. Okay, you see, most of the approach has been cardioversion and amiodarone. That's how I do it. And within a month or so, you can see that the heart goes back to normal. So at that stage, would you proceed to ablation? Or would you take the patient off amiodarone and wait for another episode of AFib, or directly go to ablation?
I think if you reverse the cardiomyopathy, I think you're pretty good at going to an ablation. The thing with amio, most antiarrhythmic drugs, you try to stop before the ablation procedure to identify triggers, which often in people with cardiomyopathy, whether it's, they can have other sources beside the pulmonary veins, and it's important to try to identify those during the ablation procedure. Certainly it's not realistic to, if you see someone with AFib, to try to get all the amio out. So you might wait for 6 weeks or so to postpone the ablation and stop the antiarrhythmic drug. But, the other medications, such as dofetilide, if they're on, which is a reasonable choice in patients with heart failure, certainly you can stop that, say 5 half-lives, and then try the procedure at that point.
Dr. Fuchs?
No, just to comment that about 25 to 30% of patients with left ventricular dysfunction develop atrial fibrillation. And one has to be very careful and start going to ablations when in fact you don't know what is the cause of the effect. So I would drop the heart rate first. And after you know that the heart rate really makes improvement of ejection fraction, you can decide to be more aggressive. But otherwise, I have faced patients actually with that situation in which the patients were referred because cardiomyopathy related to heart rate. And you drop the heart rate and the cardiomyopathy stays there. So we have to be very cautious, I think.
I think Dr. Fuster brings up a great point, and I think when you see the younger patients with a presumably tachycardiomyopathy, and if you're convinced that's the cause, then ablation certainly. But the older patients with other comorbidities, because they do coexist, I think it's very reasonable to cardiovert them and try antiarrhythmic drugs first.
Is there any way to differentiate, for example, I mean, there is data in the animal model where you induce cardiomyopathy, and they don't have left ventricle thinning. They have a large ventricle, at least on the echo. So do you go to MRI? I think it's important to establish that it's, the afibrillated cardiomyopathy, and one way is clinically, you cardiovert, put them on amiodarone, wait for a month, and you see everything revert back to normal. But do you think that there is any other method like MRI, Dr. Fuster?
I don't think so, because as you know, imaging technology may show ventricles without any fibrotic phenomena, and the patients are in cardiac failure. So I don't think, well, obviously, if you do an MRI and you see significant delay enhancement and significant fibrosis, you might say, well, the primary problem is a cardiomyopathy, but if you see a normal ventricle with no fibrosis, you really cannot tell. So,
okay, we got to move. We are running out of time, so keep your answers very brief. This question is for Donna. We often see patients, with who are in heart failure, but they're compensated, and then they go into persistent AFib and they decompensate. These patients are difficult to treat. How do you approach them?
Most of the time it's just trying to rate control them. But if there's a clear association between the development of atrial fibrillation and the worsening heart failure, then you may try to get them back into normal sinus rhythm again. But mostly it's rate control.
Srini, you want to give us some data or some information about how, in regards to the study by Natale, what is that? I think the ATAC study?
Yeah. So that was a study that randomized patients with heart failure, EF less than 40%, I believe. And ICDs, and they had a New York Heart Association class 2 or 3 heart failure. And they randomized to them of a strategy of amiodarone with cardioversion versus AFib ablation. And as Sunil alluded to earlier, AFib ablation came out superior in terms of hard endpoints, including a mortality benefit.
Now, AFib ablation, persistent AFib ablation is not very successful, like 60%. And you need, in the majority of patients, you need a second, maybe a third procedure.
Yeah.
So how do you approach, heart failure patients are much sicker, obviously. So do you use any method, like I know that you do ice, fire, and laser.
Yeah, yeah.
Do you prefer any of those, or which ones? And then, you have to intubate the patients. So how do you go about?
So those balloon
keep it short.
Yeah. Okay. I'll try to keep it shorter than your question. Balloon technologies are really for paroxysmal AFib, one-shot type of isolation for the pulmonary veins. For persistent AFib patients and heart failure patients, you need a lot more extensive ablation. And radiofrequency ablation with pulmonary vein isolation and more extensive ablation, as Dr. Fuster likes to call it, is the way to go for patients with persistent AFib. And often it requires more than one procedure to be successful.
Thank you. Well, now we go to VPDs. Now, as you know, Dr. Bernard Lown, who a lot of us are very familiar with, brought the fear of death with his VPD grading. And when I was an intern and resident in the 1970s, anybody who had high Lown grade VPDs, no matter what they had, even if they had a toothache, they were rushed to the CCU and given IV lidocaine. And we all came to know that was all bad medicine. Then in the 80s, we had a lot of interest I particularly had a lot of interest in VPDs, and I think that Milton Packer also had some interest, but he denied VPDs most of the time. But on the other side of the coin, the Holter studies in the 80s showed that frequent VPDs and non-sustained VT are very common, and their role or their predictor for sudden cardiac death was very weak because the denominator was very high. Now we have, in the more recent years, we have come to realize that VPDs can produce cardiomyopathy. And Sunil, I'm going to ask you this question. So do you think that, how do we follow these patients? If you refer a patient for VPDs, who's symptomatic, or for that matter, even asymptomatic, do you do repeat Holters? Do you do repeat echoes? Do you look for cardiomyopathy on a long-term basis?
I think, as I alluded to, if the patient is symptomatic, then we have to establish that the symptoms are from PVCs rather than otherwise. So I think, and the burden varies a lot. There is diurnal variation. So I think Holter versus now new ambulatory monitoring devices like Zeopatch are appropriate for long-term monitoring to look at the burden and symptoms. And if the patient is symptomatic with them, the success rate is very high for ablation, and the complication rates are pretty low. So I think it is a reasonable approach for symptomatic patients. For patients otherwise, I think only about 5% patients developed cardiomyopathy when they had greater than 10% PVC burden, and it is probably a very long-term chronic phenomenon like knocking off an engine. And I feel follow-up is more important there in terms of whether they are developing cardiomyopathy with echocardiogram. I do not have any data to suggest how frequently one should do follow-ups, but I would believe that a higher frequency monomorphic PVCs, those would suggest that I should do follow-ups slightly more regularly, 6 monthly to yearly, as compared to lower PVC burden.
Sean, what about PVCs in heart failure? Do you think that they worsen heart failure? Do you do anything about it?
Do I do anything about it? Yes. I prescribe neurohormonal blockers, high doses of beta blockers and ACE inhibitors and MRAs. And I say that in all seriousness because, as Dr. Fonero mentioned, when you increase the doses of beta blockers, you often do see an increase in ejection fraction, and oftentimes the PVCs will go away. So Pvc-induced cardiomyopathy does exist. However, it's extremely rare, usually more commonly seen in young individuals. And I bring this up only because 2 hours ago, a colleague handed me an EKG of a 23-year-old with, who was in bigeminy and has a cardiomyopathy, and the timing couldn't have been more perfect. But beyond that, I think for those people who are more likely to have a PVC-induced cardiomyopathy, as Dr. Fuster said, you might see less thinning of the ventricular walls. They tend to be younger. They tend to be in an RVOT pattern, things like that. And in those cases, it's appropriate to consider doing catheter ablation. However, I do agree with what Milton said, that PVCs are extremely common in cardiomyopathy. They're often there, and they often are not pathogenetic. So it's very rare that I see someone who has such a high PVC burden, 10%, 15%, in the setting of an established cardiomyopathy, that I think it's clearly worsening their ejection fraction. My approach is, again, increase the neurohormonal blockers.
Srini, are there any types of VPDs that are more causative of LV dysfunction and heart failure, or particularly LV dysfunction?
Yeah, I think just like any type of endocardial PVCs tend to be less because they engage the His-Purkinje system sooner. More broad-based PVCs, there's pretty good data about that. Broad-based PVCs in patients who already have a wide QRS, for example, they suggest a myocardial location or epicardial location for these PVCs, and they cause more dysynchrony and higher chance of LV dysfunction.
Okay, thanks. So you think that, so you believe that monitoring or getting Holters, you look pretty much for the width and the origin of VPDs, and that sometimes will tell you in terms of their propensity for heart failure.
Yeah,
or
I think it's important to
cardiomyopathy.
have a 12-lead EKG of this. And certainly monomorphic PVCs, we treat them differently, particularly from the outflow tract region or papillary muscles, than some of the heart failure patients who have 40,000 multiform PVCs. That's not really something that it may improve with suppression, but probably more amenable to antiarrhythmic drugs rather than ablation.
Okay, now let's go and proceed to resynchronization therapy. I think that there has been a lot in the last few years in terms of resynchronization, about anywhere from 20 to 30%, probably less now. People who have CHF have IVCD or left bundle branch block. So I'm going to ask the panel, I'm going to put these questions, and I want an answer yes or no. But before that, let me just say that there's been a lot of controversy, and we have known right now that only people probably with left bundle branch block improve the LV function. The data is not very good in people with narrow QRS complexes like 120, 130, and those with IVCD or particularly right bundle branch block. So the answer is yes or no. We can start with Dr. Fuster and go to Sunil and then come back the other way around. It's going to be like reentry. So CHF class 2 to 4, of course, all these patients are supposed to be on adequate medical therapy, guideline mediated. Left bundle branch block, QRS of more than or 150 milliseconds. 150, more than or equal to 150. Left bundle branch block,
yeah. Ejection fraction, yes.
Sean?
Definitely.
Definite yes.
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 Okay, great. Everybody is... No controversy there. Okay, class 2 to 4, left bundle branch block, but QRS duration now is 130.
Yes.
Yes.
Maybe.
A weak yes.
No.
No.
Okay, good. I agree with the no's. I shouldn't say that, though. The moderator shouldn't make... I apologize for that. Class 3 to 4, IVCD. QRS more than or equal to 150 milliseconds. Dr.
No.
Fuster.
No.
Yes.
No.
Maybe.
Sunil.
I think I will ask for the PR. I think the only data is if the PR interval is greater than 230 milliseconds, there is some functional mitral regurg in these patients, and they were the only one in the MEDIT CRT subgroup analysis who were shown to have improvement.
There were mild heart failure patients, though, so class 1 to 2, certainly 2 to 4 would be a different population.
Yeah, and MEDIT CRT is one trial. If you look at all the other trials, there's been substantial benefit. When you meta-analyze it, there's benefit. If you look at the real-world data in over 100,000 patients we published, there's benefit. It's not as large as left bundle, but above 150, regardless of morphology, you do see benefit, even when you exclude left bundle branch block, with MEDIT CRT being the outlier rather than the definitive answer from my perspective.
Except the guidelines are really not getting into that. Is not correct?
Well,
Into the non-left bundle, at least the European guidelines, they say absolutely not, unless it is a left bundle.
so the ACC-AHA, by giving a lower level of recommendation, so not at the class 1 or even the 2A, does give a 2B recommendation, but even that was probably a little more conservative, influenced by the MEDIT CRT analyses. If you look at the totality of evidence, that said, there is still some debate about these patients.
And I think it's also in the wider QRSs above 150 for that. That's right.
Okay, this question is for Srini. Actually, Ben Sherlock in the 1960s was working with Tony D'Amato showed in the dog model that you can, if you pace the bundle of His, you get normal activation. Subsequently, in the same lab, I studied the effect of digitalis by using the same model. And in 1977, we showed that right ventricle pacing by using single plane echocardiography causes LV dyssynchrony. And then we also showed, including Dr. Narula, that if you pace the His bundle, you can normalize left bundle branch block for two reasons. One is longitudinal dissociation within the His bundle as a cause of left bundle branch block and predestination of fibers. So in essence, my question to you, Srini, is, in bi-V pacing, we are not really physiologic. We are pacing the epicardium. Normal activation is endo to epi, not epi to endo. So why don't we use His bundle pacing more often? And what about the new technology, the WISE wireless technology, which Dr. Vivek Reddy apparently has already done some cases in Prague. Yeah. So you want to talk a little bit about that, and then I will pass on to the audience to ask questions.
I'll keep it short. So the His bundle pacing, you can normalize a lot of left bundles, but there are some that you don't. And it's not easy to do. To get true His bundle pacing is often very hard to map and very hard to do. So it's not an easy thing. And certainly, if you are able to do it, you can narrow the QRSs and get more physiologic pacing and perhaps improvement. The LV endocardial pacing thing you're talking about is the WISE CRT study, I believe. There's a couple of ways. There's studies, both preclinical and small human studies, to show that LV endocardial pacing is better than LV epicardial pacing. And there's a couple of approaches with that. There was a recent publication in European Heart where they did a transeptal and put a endocardial RV lead into the LV and showed that it was a feasibility study and good outcome, except for the fact that there's a high thromboembolic risk with that. Now, the WISE CRT is a little different. It's a little pellet-like device that's delivered retrograde and implanted into a location into the LV. Now, the transducer that communicates with that sits, and it's powered by a generator that's subcutaneous. So it communicates wirelessly with this pellet.
By ultrasound
Technology. And certainly now there's going to be a U.S. study with this. The early studies show that actually there's electrical remodeling also that occurs, meaning that not only the pace QRS is narrower over time, but the intrinsic QRS, when you stop pacing, it narrows over time also. So in addition to LV remodeling, structurally, there's electrical remodeling. LV improves and such, but again, it's early technology and it's still
Thank you.
The early data. There were some complications associated with it.
The audience can ask any questions. Yes, Sandy.
I don't understand who goes to these patients. Are they doctors, nurse practitioners? Are they senior people? And what is there a formula about how much you should push them, how much they should tolerate? Is there a formula about what you tell them in terms of possible expectations? Do people get together before they go out and see these patients? And is there a pep talk, or do you just tell them to tough it out? Or, so if you had this kind of data, it would kind of be informative about how meaningful the trials are.
So, certainly each trial can be a little different, but often they're double-blind and placebo-controlled. There's a protocol. Patients go through the informed consent process. They're told they may get sugar pill or the study drug. There's a protocol where we'll be up-titrating the medications as tolerated. Here are the symptoms that potentially could occur, the serious adverse events we'll be looking out for. that issue of each individual patient's perception, their experience, and the side effects they have in a study and how much they'll put up with. They report some. There's some that are so serious they'll come out of the study or not further up titrate the drug. I think each investigator and study coordinator have also their thresholds. In general, many medications are reasonably well tolerated. It's this issue of distinguishing between what are symptoms from their underlying condition or its natural history versus the study medication. Given that we also have a parallel group where they're having symptoms on the sugar pill, the placebo, we can often compare those adverse rates. So if patients reporting 5% fatigue on the study drug, but 5% of fatigue on the sugar pill, we can say that study drug probably wasn't inducing much of those symptoms, where the rates are much higher with the study drug than placebo. That gives us insight to what component was due to the study medication and at what doses.
It still leaves you me in the black box, because there's nothing in your description about doctoring and how you talk to the people and how you encourage them, what you listen for, you know, which is everything if you're trying to achieve a certain dose and you're in the real world. So.
Yeah, I was going to take a different tack at that, which is to say that everyone who gets referred to our heart failure disease management program, we screen for a clinical trial. And we view that as our academic mission to make sure that we're continuing to explore new diagnostic techniques, new therapeutics that we can apply to heart failure patients, not just here, but across the country and across the world. So we will screen everyone. We have a trial coordinator who goes through the inpatient heart failure list, the rapid follow-up list, the expected patients who are going to be seen over the course of the week by all of the attendings in the heart failure service down in GP1. We screen them all, and we try to get them. There's clearly a trial that's right for each one of those patients. We just need to match them up.
Yes, Jose? Yeah.
Certainly, again, like Sunil said, if you have a long PR, there's certainly data.
No, he's asking about the PR as of 170.
Normal PR. Yeah. So if class 3, and you know, I think that's
what he's asking is the IVCD doesn't fit anything. Okay. Right one.
Yeah. I think, you know, again, it's a tough question. You see these patients sometimes, and I think if they don't have many options in terms of medical therapy at this point, I think it's certainly reasonable to try upgrade to a CRT in these patients. And, you know, there is other things you can do. You can look for, not just put it blindly in different, any location it goes to. There's mapping data to suggest you find areas where the onset of the QRS to the latest segment of the LV that gets activated. If you put an LV lead in that location, they may benefit. Again, this is something that's going to be looked at in an ongoing randomized study.
Okay, if there are no more questions, thank you very much for your attention.